Hello.
Yes, you are audible.
Yeah. Can you see the screen, ma'am?
Yes.
Pediatric optic neuritis, our perspective. Unique ID is FP1352. Section Neuro-ophthalmology. Chief author being Dr. Sandhya and presenting author being me, Dr. Pooja Sukumar. Introduction. Most diseases affecting the children are different than those affecting adults, despite assignation of identical names. Adult onset optic neuritis with recognition that in the absence of granulomatous or infectious etiologies is usually a harbinger of multiple sclerosis. However, pediatric optic neuritis remains enigmatic. This is due to the inclusion of adolescents and young adults in most of the reported case series, but it is largely due to the evolution of neuroimaging and serological tests that have identified uh, which, which have redefined the demyelinating diseases. The majority of patients with optic neuritis recover visual function spontaneously. However, IVMP can accelerate the rate of recovery. The current consensus spectrum of neuroinflammatory diseases that include optic neuritis are monophasic, optic neuritis, isolated recurrent optic neuritis, pediatric multiple sclerosis, clinically isolated syndrome, acute disseminated encephalomyelitis. The investigations done are lumbar puncture, MRI, anti-MOAG, aquaporin 4. Objectives of our study was to analyze the demographic profile of pediatric optic neuritis and understand the disease cause and its implications. Study population: 7 pediatric patients were diagnosed with optic neuritis in our study population. It was a prospective interventional study conducted from October 2020 to September 2021. The demographic details, clinical presentation, investigation details were noted for each patient. MRI orbit with brain and with contrast was also performed for each patient. Patients were treated with 3 days of IV methylprednisolone, 500 to 700 milligram per day, depending on the weight, in divided doses, followed by prednisolone 1 milligram per kg weight for a week, followed by weekly tapering of prednisolone tablet. They were followed up regularly and the vision was noted at each visit. Results: the age of the patients were between 4 years and 16 years, and most of the patients were of the age group of more than 13 years, which is 71.4%, that is the pubertal age group. In our study, 4 patients were males, which was accounting to 57.1% of the patients. Bilateral presentation was more common, which was accounting to 57.1% patients again. This was a case of bilateral pediatric optic neuritis in the below image. The minimum vision on presentation was PL positive. 71.4% of the patients improved to 6 by 6 vision within 10 days of treatment, while 28.5% of the patients took 4 weeks for the complete improvement in vision. On fundus examination, the patients presented with blurred disc margins, swelling, peripapillary. Few patients also showed peripapillary hemorrhages, and very few had retinal exudates. This was one of our cases in which day 1 the vision was PL positive in both the eyes. The vision improved to counting fingers 2 meters in the right eye on day 4 and counting fingers half meter in the left eye on day 4. Day 10, the vision in both the eyes improved to 6 by 9. One of our patients showed hyperintense right optic nerve with meningeal enhancement of the right optic nerve from the proximal intracanalicular portion and the intraorbital area. MRI spine showed thin serrings from D4 through D12 vertebral levels and small posterior bulges from C4 to C5, mildly indenting the thecal sac. Lumbar puncture was also done for 4 out of 7 cases with no positive results. In our study period, the patients did not have any recurrence. Visual field test could not be done for any of the cases. Conclusion: optic neuritis in children presents with different clinical manifestations than in adults. Like optic neuritis in children are usually seen bilateral. Optic disc edema is more common in pediatric age group. Orbital pain is is less common in pediatric age group, and vision loss is much more pronounced in pediatric age group. Most patients may experience some long-term visual defects even after receiving the treatment and achieving visual acuity of 6 by 6, like limitation of visual fields. Our study limitation was lack of visual field analysis post the recovery. The role of puberty in modifying the presentation and risk associations was unknown. Prospective studies are required to resolve these diagnostic and management issues. The conversion rate of these cases to multiple sclerosis is also unknown. A sense of urgency has developed to understand the systemic risk of pediatric optic neuritis, as new therapies have developed to control the demyelinating disease. And much more studies should be encouraged in this particular field. No financial disclosure. Thank you.
Pooja,
Yes, ma'am.
pediatric cases, what is the most commonest cause of bilateral optic neuritis?
Ma'am, I couldn't hear you.
Most commonest cause for bilateral optic neuritis in pediatric cases.
Multiple sclerosis, ma'am.
In children, pediatric cases, commonest cause.
Demyelinating diseases, ma'am. NMO.
What is Youth syndrome and Pulmonary phenomenon? Do you know? Pooja,
Ma'am, I can't hear you.
what is Youth syndrome? Pulmonary phenomenon is what in optic neuritis.
Ma'am, Youth syndrome is while using warm water, the patient has more diminution of vision.
Pulmonary phenomenon.
Pulfris phenomenon is pendular movement of the objects, ma'am, while viewing the object.
Dr. Pavitra? Am I audible? Hello? Pavitra? Doctor, can we move to next presentation? Hello? Dr. Rashmi, are you there?
Yes, ma'am.
Okay, you can present.
Good morning, everybody. My topic for presentation is rare manifestation of a reactivation of subclinical multiple sclerosis following the COVID-19 vaccination. Purpose: it is to report a initial clinical manifestation of subclinical multiple sclerosis post COVID-19 vaccination. Introduction: multiple sclerosis is an autoimmune demyelinating disorder. It is commonly manifested by visual system involvement. Hence, multiple sclerosis can present initially with the ophthalmic symptoms. Multiple sclerosis eye manifestations include both the afferent and the efferent visual pathway. In afferent pathway, most commonly it affects the optic nerve. Rarely it affects the optic tract or optic chiasma. In efferent visual pathway, it affects the motor supply to pupil and to the extraocular muscles. Optic neuritis, it is the most common ocular manifestation of a multiple sclerosis. Introduction. Infections induces the autoimmunity, same way vaccination causes the immune activation. Mechanism here: the possible structural similarities between the microbial epitomes and the epitomes of the CNS tissues. This causes the cross reaction of the antibodies via the molecular mimicry. Here you can see after the vaccination, there is an induction of the activation of the autoreactive immune cells either by the molecular mimicry or by the bystander activation, novel autoantigen, or sequestered CNS antigen. And because of the autoactivation of the immune cells, they further enter into the systemic circulation to cause the autoimmunity. Case report. Here is the 24-year-old female came with a complaint of double vision in the left gaze and inability to move right eye inwards from 4 days, which is sudden in onset and non-progressive, which she developed 2 days after the COVID vaccination, that is first dose of the Covishield. There is no complaint of a diminution of vision, redness, pain or watering, no history of a to and fro movement of eyes, no history of ocular trauma or ocular surgery, no history of fever, and there is no similar history in the family and no systemic illness. Examination showed Visual acuity being 6/6 in both eyes. Anterior segment cornea is clear. Anterior chamber is normal depth in both eyes, with the pupil reaction being normal in both eyes. Lens and fundus are normal. On extraocular movement examination, you can see in a primary case normal movement, and in all other cases there is a normal extraocular movement, except in the right eye you can see there is a limitation of a adduction of the right eye. On doing the force detection test in the right eye and force generation test, and both tests were negative. Diplopia chart showed right eye horizontal gaze palsy. Then provisional diagnosis of a isolated medial rectus palsy, which is secondary to COVID vaccination, was made. Then patient was advised to for all routine investigation and sent to neurology department with the advice of MRI brain and orbit to rule out any intracranial or intraorbital pathology. You can see MRI brain and orbit with a contrast was done, which showed images showing multiple discrete flare TW hyperintensities noted in bilateral, periventricular, pericallosal, noted which is perpendicular orientation to the lateral ventricles, with the post-contrast enhancement of a few lesions noted. This suggestive of sequelae to any demyelinating disease and most probably considered as the multiple sclerosis. Down image shows the MRI orbit. MRI orbit shows the which is normal. Then all routine investigations were done, including HIV, HBsAg, VDL to rule out any infective pathology, which was negative. ANA profile was negative. Anti-aquaporin 4, NMO, IgG antibodies to rule out neuromyelitis optica was also done, which is negative. Then anti-MOG, that is myelin oligodendrocyte glycoprotein, to rule out any autoimmune demyelinating disease was also negative. CSF analysis was also normal. Result. Final diagnosis of acute cerebral demyelination or reactivation of a subclinical multiple sclerosis, which is secondary to COVID vaccination, was made. Patient was treated by injection methylprednisolone 1 gram per day, which is for 5 days, following which patient was symptomatically better, hence discharged by explaining about the recurrence possibility. Conclusion. Vaccination-induced oculomotor nerve palsies are very rare. Pathophysiology behind the post-COVID vaccination post-vaccination nerve palsy is unknown, but it is hypothesized that it could be due to the immune-mediated damage, which is resulting in the demyelination. Multiple sclerosis is a debilitating disease of the central nervous system, and MS cannot be caused by vaccines, either by inactivated or by the live vaccines. Systemic vaccination worsens the multiple sclerosis. Hence, vaccination will lower the risk of relapses by reducing the risk of infection. Hence, vaccination is highly recommended in MS patients. MS is a chronic disease thought to be caused by immune-mediated mechanisms. Thus, immune responses caused by vaccination affects the immune system. And in our case, isolated MR pulse which is seen, it is a very rare manifestation of a multiple sclerosis, and it is the first case reported in India as far as we have seen here. These are my references. Thank you. Hello, ma'am.
Hello.
Hello, ma'am.
Hello.
Hello.
Yeah, one question is there. What are the other causes other than the multiple sclerosis for isolated MR palsy?
Ma'am, usually MR palsy, it will be because of, as we have seen the article, isolated MR palsy as such, it is very rare. And
Yes.
it will be seen in autoimmune encephalitis, ma'am. Autoimmune demyelinating disease. That too in young patients.
Okay, only one MS is multiple sclerosis is only one cause or any other cause is there?
Neuromyelitis optica can also be the cause, ma'am. And because of a vaccination, that acute demyelinating disease might also happen post-COVID vaccination, post-vaccination, ma'am. Idiopathic inflammatory demyelinating disease might also be one cause.
Okay.
Dr. Rashmi, was COVID antibodies done?
No, ma'am, we didn't do.
Like, on what basis would you blame the vaccine in this case? Why is it not a coincidental finding?
We thought immediately 2 days after the COVID vaccination, she had the symptom, and there were no past history, no family history, anything, ma'am, and there was no history of any fever, any systemic illness.
Yeah, but it kind of sounds like it could be a coincidence, right?
Ma'am, it might be.
Probably if you had done the COVID antibody titers, some kind of correlation could have been done.
That antibody, ma'am, since she presented very early, that antibodies takes very long time to develop, so we didn't do any antibody test. Hello, ma'am.
Hello.
Hello, ma'am.
Dr. Rishika?
Yes, ma'am. Shall I start, ma'am?
Yes, you can start.
Good morning, everybody. I'll be talking about a study to assess macular ganglion cell complex in compressive optic neuropathies and to analyze its relation with perimetry. The background for a study was that automated perimetry is a standard for assessing visual function and monitoring disease progression in neuropathies. Macular ganglion cell complex in OCT is an objective, quicker, and repeatable method of assessing optic nerve dysfunction. According to papers like Dicker et al., GCC is more reliable than fields or even RNFL analysis in chiasmal compression. The macular GCC parameters are also theoretically superior over even peripapillary RNFL parameters in early diagnosis because it has been experimentally demonstrated that RGC's anomalies precede the axonal loss. Hence, we decided to compare GCC with visual fields. Our aim was to assess macular ganglion cell complex in compressive optic neuropathy in chiasmal lesions and analyze its correlation with automated perimetry. We included cases of compressive optic neuropathies, the tumors compressing the chiasma, both cellular and supracellular lesion, including pituitary adenoma, craniopharyngiomas, supracellular meningiomas, following complete neurological examination confirmed on MRI, which were referred to us by a neurosurgeon. We excluded patients having retinal pathology, unable to do a reliable field test, or patients with glaucomatous optic neuropathy or ocular hypertension. We studied a total of 105 eyes of 53 patients, which were referred from the neurosurgeon in a tertiary center, meeting the inclusion and exclusion criteria for a period of 1 year from November 2020 to November 2021. Patient demographic details and history was collected. A complete ocular examination was done. All patients underwent GCL plus analysis on TopCon. A macular cube of 512 by 128 scan was done, and visual fields of 30-2 with a size 3 stimulus. The results obtained were compared and data was analyzed. This is our sample Excel sheet where we have checked the GCL in all the quadrants and global GCL thinning compared with the field as well. This is a case of a 27-year-old lady with pituitary macroadenoma. On the left-hand side, we can see the fields having bitemporal hemianopia. This is the GCC of the right eye having a nasal thinning, and the left eye also showing a nasal thinning. So this is a case of binasal macular GCL thinning corresponding to a bitemporal hemianopia. This is a case of a 30-year-old gentleman with pituitary macroadenoma, where the fields were showing left homonymous hemianopia. And this is the right eye showing a temporal hemifield defect. This is the left eye also showing the temporal field defect. This is a case of a prefixed chiasmal condition. Our results were as follows. We studied a total of 105 eyes of 53 patients. Patients aged between 16 to 62 years were part of the study. Majority of our cases were pituitary macroadenoma, about 75%, followed by craniopharyngioma, meningiomas, and 1% had a Radke cyst. The field changes were majorly bitemporal hemianopia because of chiasmal compression, including superior dense, inferior dense, or a center encroaching field defect, which included 94% of our patients. This was followed by homonymous hemianopia in 3.7%, suggestive of prefix chiasma, and junction scotoma in 1 patient. Our GCC analysis showed average thickness of 62 micron. This is in comparison to a normal of 84 to 90 micron thickness, and nasal GCL was commonly involved to be affected. In correlation with the visual field, we saw that in 90% of the patient, the GCL was corresponding to the field defect. In 5% of the patient, GCL showed more changes or was worse than the visual field effect. In 3.8% of the patient, the field effect was more than that shown by GCL. So in discussion, we noted three things in compressive chiasmal lesions. There is a significant correlation between the field effect change and ganglion cell layer loss. There could be a scenario where there are changes detected by GCL, which could precede visual field loss seen on visual field change, contributing to an earlier diagnosis and presumably a better visual outcome. The corollary is also true. In some situation, there could be visual field loss which occurs suddenly, as in compression from a pituitary apoplexy. The perimetry will show a field effect before OCT can detect any thinning on RNFL or even GCL. In this also, it calls for an early intervention. To conclude, GCL analysis is reliable, quicker, and an objective tool which is comparable to visual field. GCL assesses the structural component of optic nerve, where visual field is a functional assessment of the optic nerve. And GCL should be a part of assessment of optic neuropathy, along with automated perimetry to assess damage and predict visual outcomes. Thank you.
Rishika?
Yes, ma'am.
Where is the GCL thickness is helpful in which are the neuropathies, optic neuropathy, which type?
In glaucoma also, in pre-perimetric changes, GCL is helpful, ma'am.
Yes. Okay.
It can be done in other it's proven to be effective even hereditary, toxic, nutritional neuropathies as well.
Yes.
What's the duration to get visual field effects and GCL thickness?
Sorry, ma'am, it's not clear. Can you please repeat?
Duration. How much time it will take to affect GCL? Any studies are there?
Duration of GCL and field change, ma'am?
Field changes. Which one is
there are some studies which says that GCL changes can precede field change. There are also other studies which says that after an acute field loss, GCL loss may take up to 3 months to 2 months also, ma'am.
Okay.
Dr. Sandhya?
Thank you, ma'am.
Okay.
Good afternoon. Good afternoon, everyone. My topic for today's paper presentation is a rare case of linezolid-induced toxic optic neuropathy. Introduction. Linezolid is a member of a new class of antimicrobials known as oxazolidinones. It shows activity against multidrug resistant tuberculosis, MRSA, methicillin-resistant Staph aureus, and Streptococcus. We report a case of toxic optic neuropathy due to linezolid, which occurred in a patient who was on treatment for multidrug resistant tuberculosis. Coming to the case report, a 40-year-old man presented to our OPD with complaints of diminution of vision in both eyes for the past 25 days, which was gradual in onset, painless, and progressive. Medical history included treatment for multidrug resistant tuberculosis on treatment with linezolid 600 milligrams, clofazimine 100 milligrams, levofloxacin 100 milligrams, cycloserine 750 milligrams, and pyridoxine 100 milligrams once a day for the past 7 months. He was also a known case of type 2 diabetes on treatment for the past 8 years. On examination, his best corrected visual acuity was found to be counting fingers up to 2 meters in both eyes. Color vision in both eyes was abnormal. Anterior segment was unremarkable in both eyes. Pupils were 3 millimeters, round, regular, reactive to direct and consensual light reflex. On fundus examination with indirect ophthalmoscope, mild temporal disc pallor was found in both the eyes, with the rest of the fundus being normal. OCT was done, which revealed RNFL thinning in the right eye, which was more in the inferior and temporal quadrants. The patient was sent to neurology to get a visual evoked potential done. This is the report. Shows the pattern reversal VEP was done, which showed prolonged P100 latencies in both the eyes and reduced amplitude from the left side. Linezolid-induced toxic optic neuropathy was suspected as the patient was not already taking any ethambutol, and tab linezolid was discontinued after discussing with the treating chest physician. Vitamin B complex tablets were prescribed once daily for 1 month, and patient was asked to review after 4 weeks. When the patient came back after 4 weeks, his color vision was restored to normal, and vision had improved to 6/24 in both the eyes. Discussion. Toxic optic neuropathies are characterized by gradual, progressive, painless, bilaterally symmetrical visual loss affecting mainly the central vision and causing central or centrocecal scotomas. Linezolid inhibits protein synthesis by preventing formation of ribosome complex that initiates the protein synthesis. Linezolid is usually well tolerated with few described adverse effects. Serious adverse effects which demand withdrawal of the drug include myelosuppression, peripheral and optic neuropathy, lactic acidosis, and serotonin syndrome. Linezolid is recommended by the WHO to treat drug-resistant tuberculosis as a medicine with unclear efficacy. However, there is limited data available regarding the efficacy and safety of linezolid in MDR-TB, since it is always administered as part of a combination therapy with other drugs. Although ethambutol is the most common ATT drug implicated to cause toxic optic neuropathy, it is important to know that toxicity due to other ATT drugs is also a possibility. With increasing emergence of MDR-TB, ophthalmologists and physicians must be aware that monitoring of visual function is important in patients on long-term linezolid therapy, and that early recognition of toxicity and discontinuation of drug results in very good visual recovery. These are my references. Thank you.
Hello.
Yes, ma'am.
Yeah, you told the mechanism of action, how it acts is inhibiting the protein synthesis. What is the other mechanism of action? What does it affect at the cellular level? Which structure? At the cellular level, which structure it affects, the linezolid drug?
Inhibits the protein synthesis, ma'am. Inhibits the initiation of protein synthesis.
Which it affects the mitochondria. It causes
Yes.
the mitochondria function, and that's how it affects the optic neuropathy. Okay. Other than the optic neuropathy, what are the other side effects of linezolid?
Other things are myelosuppression and serotonin syndrome are known to be caused.
How other than this, what other than the diminution of vision, acute loss of vision, how the patient may present to you?
Patient may present with central scotoma because not being able to see, or color vision dyschromatopsia they might have.
Okay. Does it not cause peripheral neuropathy?
Yes, ma'am, it can cause.
Yes. Okay.
Dr. Sandhya? Okay, Dr. Narayan? Sorry, Dr. Nayana? Are you there? Dr. Nayana? Doctor? Hello, doctor. Am I audible?
Yeah, you're audible. 3 of them have not come, is it?
Yes, ma'am.
Hello, ma'am.
Yes.
Hello. Good morning, ma'am. Ma'am, myself, Pavitra. I have not yet presented, ma'am.
Yeah, whoever is not presented, finish.
Yes, ma'am.
Yeah. Dr. Pavitra, go ahead.
Ma'am, yes, ma'am. I'm sharing my screen, ma'am. Ma'am, is my screen visible?
Yes, visible. Go ahead.
Good morning, everyone. I am presenting a case report of optic neuritis masquerading Foster Kennedy syndrome. Chief author is Dr. Sita Lakshmi, ma'am, and co-author is Dr. Lakshmi. Coming to the introduction, optic neuritis is an inflammatory disease of the optic nerve that typically manifests as an acute visual loss and pain upon eye movements. The causes of optic neuritis could be from demyelinating optic neuritis or from a severe immune-mediated demyelinating disease affecting optic nerve as a part of neuromyelitis optica spectrum disease. Or it can be because of infection, autoimmune diseases, vaccination, and idiopathic. Optic neuritis classically presents with acute to subacute visual loss, pain with eye movements, and dyschromatopsia. Although a vision loss is usually monocular, involvement of both eyes can occur usually in children. Typical form of optic neuritis occurs idiopathically or MS related, has good visual recovery. In contrast, the majority of atypical optic neuritis has poor visual recovery. Coming to the case report, a 16-year-old a girl presented with chief complaints of diminution of vision.
Your slides are not changing. We can only see your first slide.
Ma'am, just a minute, ma'am. I'll just try to. Ma'am, it's visible now, ma'am?
Yes, yes.
So coming to the case report, a 16-year-old girl presented with complaints of diminution of vision in left eye since 15 days. Dull aching pain was present on ocular movements, and she also gives history of decreased vision in the other eye since 3 years. No history of trauma, headache, nausea, and vomiting, no significant family history. Next, coming to the ocular examination, a vision was hand movements positive with projection of rays accurate in both eyes. Slit lamp examination reveals sluggishly reactive pupil in both eyes, and the rest of the anterior segment was normal. Next, coming to the slit lamp biomicroscopic fundus examination. On right eye examination, the optic disc is pale with defined margins, physiological cup is obliterated, blood vessels are normal, and foveal reflex is present. Coming to the left eye examination, optic disc appears hyperemic with ill-defined blood margins, and the physiological cup is obliterated. The veins appears dilated and tortuous. Arteries appears normal, and the foveal reflex is present. Next, coming to the investigations, anti-aquaporin 4 IgG antibodies were negative, and anti-myelin oligodendrocytic glycoprotein antibodies were also negative. MRI brain with MRV with orbits was done, and the impression was left optic neuritis, normal study of the brain parenchyma, and the normal MRV study of the brain. A visual evoked potential was done, and it showed prolonged P100 latency in both the eyes. A treatment given was injection methylprednisolone 1 gram in 500 ml NS for 3 days, and then tap prednisolone was continued. A multivitamin injections were given for 5 days. And after 10 days of follow-up, the patient's right eye findings were same with hand movements, positive vision. And on fundus examination, the optic disc appeared pale. On the left eye examination, the vision improved to counting finger 1 meter, and the optic disc margins, which were blurred, started resolving. Now, coming to the discussion, optic neuritis is essentially a clinical diagnosis, so a careful history and examination are essential in differentiating a typical optic neuritis from atypical and infective causes. If atypical features are present, urgent further investigations are indicated to find out causes of inflammation of the optic nerve head and treat them accordingly. While the majority of the patients of typical optic neuritis recover without treatment, on giving intravenous steroid, vision recovery is faster and had less chances of recurrence. Early diagnosis based on clinical presentation plays an important role in treating optic neuritis patients. Coming to the conclusion, this case highlights the incidence of bilateral optic neuritis occurring at different time frames, masquerading Foster-Kennedy syndrome. These are my references. Thank you.
Hello.
Hello, ma'am.
Which condition you see unilateral papilledema?
Ma'am?
Unilateral papilledema.
Ma'am, it can be seen in cases of multiple sclerosis, ma'am.
No.
Or
papilledema usually is bilateral.
Ma'am, papilledema, yeah.
You see unilateral papilledema.
It can be seen in cases of Foster Kennedy syndrome.
Anything else? What other causes? Foster Kennedy syndrome. Which tumors will cause Foster Kennedy syndrome?
Hello, ma'am.
Which tumors will cause Foster Kennedy syndrome?
Ma'am, frontal tumors.
Yeah. What are other causes for unilateral papilloma?
Ma'am, it's not clearly audible, ma'am. Other causes of?
Papilloma. Unilateral papilloma. One is Foster Kennedy syndrome. Anything else?
Yes, ma'am. It can be a pseudo Foster Kennedy syndrome can also.
What is that? Okay. Where else you see unilateral papilloma? Only one line you are seeing it. Usually papilloma is bilateral, but you are seeing in only one line now.
Hello, ma'am. Bhagya ma'am, I think all are finished their presentation.
Thank you. I think two are didn't present, no? Dr.
Yes,
Sandhya and Dr. Naina.
Yes, ma'am.
Yes. Okay.
Naina has not presented their papers.
Yes.
Dr. Naina, and who's the other one?
Dr. Sandhya. Dr. Sandhya and Dr. Naina have not presented it.
Yes, ma'am.
Yes.
Yes, ma'am. Yes. Thank you, ma'am. Thank you.
Okay.
Okay, ma'am. Thank you.